Now we turn to a speaker who already presented earlier today. It's Dr. Clemens Wittenbecher. He is an assistant professor in precision medicine and diagnostic at the Columbus University of Technology. And he specialized on molecular profiling, particularly metabolomics and lipidomics, and they investigate the relationship between diet and cardiometabolic diseases using these technologies combined with diet intervention studies in prospective cohorts. And his objective is to refine dietary guidelines and develop biomarker-driven decisions.
Yeah, sorry to be back, but I didn't ask for it, but I could also not decline to speak between Jordi and Meitner. I decided basically to continue a little bit one topic that I started in the previous talk and have present more my thoughts or discuss with you the thoughts that I have regarding how could that be translated into more precision in actually delivering dietary interventions for chronic disease prevention. And so I think that it is important to, like Rikard mentioned, these different definitions of precision nutrition that we have in our head. And for me, precision nutrition is a larger term than personalized nutrition that uses algorithm diets to individualize dietary behavior. And I think we can have achieved many of the potential benefits of more precision with more infrequent biomarker measurements that maybe use less resources and also integrate more readily with current healthcare systems that have infrequent blood sampling for specific high-risk populations and target basically preventive interventions based on such infrequent measurements. And for that, to discuss that, I want to go a bit through different types of biomarkers and how they, what their purpose is and how they are evaluated. So let's start with exposure biomarkers that have a very clear function to measure basically the presence of an exposure and differentiate between people who have that, for example, dietary exposure, and who don't have them. I think Chi will talk about dietary biomarkers and our ability or difficulties to measure dietary exposures objectively. And I think this is a little different when we compare that to response biomarkers that are actually not mainly tuned to objectively measure what you eat, but rather in the dietary context, but rather want to have comprehensively assess how the organism responds to specific dietary challenges. And we can, and these responses are basically not equal among every individual, and we can potentially differentiate between subgroups of populations that respond to specific dietary challenge biologically, whereas others respond differently or don't respond at all. And then another purpose of a biomarker is risk assessment. So that's usually, if we talk about risk biomarkers, that's a static definition where we differentiate at some specific time point between people at high risk of developing a disease versus those who are at low risk of getting this disease. And then if we put that into a more dynamic context, we have monitoring biomarkers that can basically track risk over time. So we can differentiate with the monitoring biomarkers between people who change their risk status, either improve or get into a higher risk category versus those who remain stable. And then finally, what is usually, according to the FDA definitions, defined as a predictive biomarker is really a biomarker that predicts the change in risk according to a specific intervention. For example, a dietary intervention where we have a group that or where the biomarker differentiates at a specific time point between a group that will have an effect of the intervention versus those where this intervention is not effective. And if we think now into of the organism as a system that basically is constantly challenged by dietary inputs, and then has a short-term metabolic response, a longer-term metabolic adaptation, and only if this dietary input has adverse effects and persists over weeks, months, probably years, that results in preclinical changes that actually then at some point translate into the incidence of a disease, for example, cardiometabolic disease, where we know that is mainly driven by diet and lifestyle behaviors. And then if we look into the function of biomarkers, we talked about dietary intake biomarkers that really want to measure what goes into the system, diagnostic and prognostic biomarkers that are much more related to what type of disease is developed, perhaps subtype of disease, and also how do we project the risk of complications, etc. Here we want to be both sensitive but also very specific, because we want to know what exactly goes in, or the best possible scenario, distinguish between specific subtypes of diseases so that we can be very specific, classify people in very specific groups. Whereas on the other hand, we also have this surveillance of response, the prediction and monitoring biomarker, and also surrogate biomarkers that measure these preclinical changes, where we are more concerned about sensitivity than specificity, because it's maybe not, especially in relation to diet, it is really important to measure changes precisely, than being, for example, concerned about that this metabolic response is only triggered by one specific dietary component. Maybe several dietary components converge on the same metabolic pathways, but they are important to measure the long-term effects of diet on disease outcomes. So I think for actually more precise preventive interventions, it's we are not doing very well with the current biomarkers. So for example, LDL, HbA1c, all this is relatively static and relatively broad categories, and not optimized to really monitor the effects of specific components of the diet on long-term disease risks. And so the point that we are interested in is to have actually not genetics, but metabolomics and lipidomics, where we know that they are very informative in relation to long-term disease risk. But so there are several very well-established metabolites and metabolic pathways that are clearly related to type 2 diabetes risk, for example. And then we also see clearly that there is an overlap between these risk-associated metabolites and lipid metabolites with the compounds that are actually changing in response to specific dietary exposures. And here I want to go back to this combination of trials and cohort studies, where we really went to the steps of evaluating, does that work as a sensor for the metabolic adaptation? Does it do changes in these these compounds that are influenced by diet actually translate into changes of risk? And can we perhaps also use them to stratify and find out which populations would benefit most from dietary interventions? And so what we did here I can, okay, I'm missing one slide. Okay, but what we did is to first look into this DIVAS dietary intervention trial, where we have high plant-based unsaturated fat intervention group, and the control group has a very constant diet, but is mainly getting their fat content through saturated fat from dairy products. And then we simply summarize all the lipid metabolites, and this is the group-specific fatty acid composition of several lipid classes. So it's very plausible that this is reflecting the influence of the fatty acid composition in the diet. And everything that changes significantly during the trial is summarized into a sum score. And then we can see these are the predefined biomarkers, and only non-HDL cholesterol is reduced. And on the variant standardized scale, there's a stronger effect on this multilipid score that basically summarizes the diet-induced changes of these lipid metabolites. And then we use the lipogain trial to replicate a subset of these metabolites. We see very consistent intervention effects through a similar unsaturated for saturated fat substitution in an independent trial. And then we basically use the same lipidomics data in the EPIC Potsdam cohort to replicate that or to reconstruct this multilipid score and scale it on the difference that was induced by the dietary intervention to extrapolate the risk association with CVD risk and type 2 diabetes risk. And when we compare that, it captures substantially more of the extrapolation of both risk reduction of CVD and type 2 diabetes that we would expect by this diet-induced change in this composite lipid metabolite marker is much stronger than what we would expect with the standard surrogate markers that were used in that trial. And we see that not only in the EPIC Potsdam cohort, we see it also very consistent effects of the diet and very consistent risk associations in the nurses' health studies. And what I think is also very interesting here is that this is related to this monitoring of risk. The changes in risk adjusted for the baseline levels actually inform changes in subsequent type 2 diabetes risk, which is something when we think about like applications in a clinical setting, which is really critical that we have a marker that changes in relation to actual interventions. And then finally, what we did, I mean, I agree with you, Jordi, it is a post hoc analysis of an existing trial, and it is only informing in that way a hypothesis, but we saw a significant interaction between the multilipid score and the diet intervention in the Predimed study. It was mentioned like several times. The Mediterranean diet intervention in Predimed prevented type 2 diabetes, and the significant interaction, we followed it up with a stratified analysis, and we see the diabetes reduction in the pooled analysis. But if we stratify by these pre-intervention multilipid scores, only though the subpopulation who had an adverse multilipid score level at baseline actually experienced a significant reduction of type 2 diabetes risk. So that does not mean that for other purposes, the diabetes in the Mediterranean diet intervention is not useful in terms of diabetes prevention, but it appears that it might be possible to identify a population subgroup where the multilipid or the lipid metabolite profile indicates an adverse dietary fat quality and target the dietary interventions in terms of diabetes prevention to this subgroup. So what I want to emphasize here is that I think that specifically metabolomics and lipidomics has this overlap between being very sensitive to dietary interventions and very consistently associated with disease risk, and that therefore it can provide or is a possible resource for really optimizing these infrequently assessed precision nutrition biomarkers to monitor the effect of dietary risk prevention and also potentially target the dietary interventions more specifically to high-risk subgroups. Thank you.
Thank you very much.